I'd like to welcome you all to this SDSMA presentation on safe and effective tapering of opioids. Our speaker today is Dr. Christopher Dietrich. Dr. Dietrich is a physical medicine and rehabilitation physician. He practices at the Rehab Doctors in Rapid City, and he currently serves as the president of the South Dakota State Medical Association. Dr. Dietrich received his medical degree from the University of South Dakota School of Medicine and completed his residency and specialty training in physical medicine and rehabilitation at the Mayo Clinic. Dr. Dietrich is board certified by the American Board of Physical Medicine and Rehabilitation and has special interests in pain medicine, sports medicine, and interventional pain procedures. At this time, I'll turn the presentation over to Dr. Dietrich.
Smart. We'll begin. We'll pause a couple of times, and if there's any questions, we'll leave a remark to kind of open up and for questions. Today's talk is about safe and effective tapering of opioids. This is part of SDSMA's opioid education. This particular seminar is the South Dakota Department of Health grant, looking at improving physicians' opioid abuse, evaluate for opiate dependency, how our responsible stewards and prescribers, how we monitor and review use of opiates, and specifically try to come up with some alternatives to opiate use. We have several objectives throughout several of these educational modules as far as how to assess for pain, how do we document this, use the DMP tool. Several educational outlets, live presentations. This is a based curriculum and live curriculum. The SDSMA has a toolkit for opiate prescribing, and we'll kind of reflect some. You see the checklist for prescribing. It's been published by SDSMA and has several good points and guidelines on how to proceed with appropriate prescribing. Talk about what is available to us and to evaluate addiction. We're going to try to create a plan on how to taper off of some opioids. Talk about some alternatives to opioids or how we use a treatment ladder to look at that. Some resources available if we recognize problems, and then discuss how do we monitor these patients and how do we review, what are we looking for. Lots of statistics in regards to addiction and to opiates. World, lots of abuse of opiates in the U.S., significant amount of opiate abuse, and what we're seeing, and specifically in South Dakota, just off of our opioid task force data presented last week, there is a significant growing problem of heroin and methamphetamine abuse in South Dakota. Difficult to assess, but a lot of these people probably addicted to medications through an initial opiate prescription, and so they have their start somewhere. Percent of these opiate reported that their prescription was for regular or prescription for pain relief following a procedure or some sort. In heroin users, that first opiate was a lot of what started that process. So, as a prescriber, what can we do? What do we come up with? We want to assess the risk of addiction. We'll talk about some tools to use that, the risk of the individual. We want to assess pain. Obviously, we still ask about pain. I think more important, and a lot of times what gets overlooked, is function. People functioning on medications, or how are they functioning on medications. If your pain score remains the same, whether you're an opiate or not all that helpful, but even more telling is what is their level of function. If you're still on the couch, if you're still bedridden, if you're still so ambulatory or functioning in the ambulatory setting, then that to assessment of are you accomplishing some functional goals or measures. Well, behavioral health and some adverse drug behaviors with informed consent, that's the signed agree to treat with opiates. We monitor this pain and function throughout the process, and we try to progress towards some mutual treatment goals. Now, not always does the patient have the same goals as the prescriber, and that communication becomes critical to try to work some common goals or some ground we can mutually agree upon. We have treatment agreements for long-term opiate therapy, and specifically coming to agreement on how you're going to approach this, what the ground rules are, and what's happening. Document, we can't say this enough, and now with some of our new state statutes, this is even more increasingly important. This basically just talks about how through a patient, and this is just one example or a way that we set an evaluation of what's physical status, their mental status, do they have potential for abuse, socially are there issues, try to get treatments first, non-pharmacologic treatments, physical therapy, yoga, massage, acupuncture. There's a non-opiate pharmacologic options with antidepressants, neuropathic pain agents, non-anti-inflammatories, acetaminophen, a variety of topical treatments, over-the-counter treatments that often can be full. We use a lot of modalities in physical therapy: heat, ice, electric stim, and to ways to get symptom relief or alleviate things without going straight to an opiate. We obviously want to assess functional goals. I mean, is the goal return to work? Is the community ambulator and get to the grocery store and back? Are they a weekend warrior trying to get to skiing or hiking or biking, playing golf? What are we trying to accomplish? Either continue with the drug going, or maybe try to taper off some of what they're already on. We change the therapy, assess, maybe some different medications would be in line, put some interventions, injections, treatments. An opiate treatment was considered for certainly would want to assess for mis or abuse, for other comorbid medical conditions, and then to start that at the absolute lowest possible dose for a long time. And that needs to be very clearly communicated to the patient that this is to facilitate participation in therapy or to facilitate improvement, that the chronic long-term strategy or plan. The referral to a specialist, whether that be orthopedic neurosurgery, PM&R, interventional pain, one along those lines if additional treatment needed to be pursued. What we now are recognizing is that there are an awful lot of patients that have addiction issues or are in need of some treatment services. A lack of knowledge of what these services or resources are, either to the patient or the prescriber, financial resources to afford some of these programs, depending on their insurance or financial status. Lots of individuals are not getting appropriate addiction services or care. There are prior auths for either patient-assisted treatment, interventions or procedures, physical therapy, since like acupuncture or other pharmaceutical options may or may not be covered by insurance. Surgery. There's a variety of access or patients that this, and we're going to talk about some of these services or some options that are available, some things that we're trying to communicate. I guess our state to see some improvement, specifically along the addiction lines and the mental health lines. Nobody has seen or received some information, but during some screenshots, there's a lot of information that's currently out there from our state medical association about education. And if you go to our website, under prescription drug abuse, a tab for providers or for patients with lots of information, links, pertinent information. Under providers tab, also underneath are links to a variety of resources that are available. The SMA white paper for prescribing chronic cancer pain, rhythms, the C dose calculator for opiates and MME calculation can be very helpful. There's agreement forms, there's a different provider resources and links as well. I'd like to point out the Drug Addiction Services and Treatment tab. Another part of it shown later. There's lots and lots of links to different community services that are available. So there are different assessments for pain, as well as pain assessments. There's patient assessments for other conditions as far as depression. The -R is a tool used to predict abuse, or if they're more likely to have abuse. It sort of ease the prescriber into more frequently doing more frequent drugs or assessments, looking for psych comorbidities that could play a role in complications with treatment. Different components for patient education, and several different service links for addiction. We already about the assessment tools. The SOCHAR is commonly used, and we have to attach that to our agreement to treat with opiates, so the patient will complete this going through the agreement to treat, providing information and rules. We look for depression, anxiety, and some other comorbidities, only if they're reported or there. Anxiety scale or score is pretty quick and easy, but it can give you some information on where your patient is at and where they're coming from. And what we're going to talk about is we've identified a patient, or the patient has come to our doorstep with high-dose opiates or opiates at some dose that we're not specifically comfortable with, or we would like to try to taper down on a dose. There's still components that I said that Dr. Yuthi wanted to comment on there.
Tell you what, if there's, give me just 1 second. Line should be open, Dr. Yuthi. Go ahead and we should be able to hear you. Line is open. Let me check Dr. Dietrich to see if he sent a message in, and I'll see if I can see that. If you want to proceed, and I'll let you know.
So one of the, if there's questions, just mark a message or let us know. So when considering tapering to reduce the dosage, obviously there's several things that could trigger that. The patient comes in, requests a dosage reduction, or wants to get off the medication. About clinically meaningful improvement in pain and function. The CDC came up with at least 30% improvement on a PEG scale. I think looking at functional improvement, are they more independent? Are they more active? Have they increased activity? Are they back to work? Ambulator? Are they recreational pursuits? Those types of things. We look at Dakota now has pegged 90 mMEs of morphine as the maximum ceiling. I think if they're greater than 50, or at whatever level you're comfortable with your patient, trying to titrate down and see how far you can taper and work the patient down. Specifically, the CDC talks about if they're combined with benzodiazepines, we would really like to reduce those dosages. And I would argue try to eliminate one or the other. My psychiatry colleagues, at least whatever, are not particularly fond of eliminating the benzodiazepines in some of our true anxiety cases or patients, and we're trying to figure out alternatives to opiates for pain management. I think they show any signs of substance use disorder, work problems, misuse of prescriptions, failed drains, stolen meds, a variety of the common issues. That's enough indicator to really consider strongly tapering. I think Dr. Mills had Papa is speaking or asking a question, as well as Dr. Yuthi.
Not the case. I am here.
Okay. It might just show that you're on.
I think so.
Okay. So, and I think obviously if there's any overdoses, serious adverse events, any to emergency room visits or various events, we would certainly want to taper or work with their team to taper down on that. Any signs for overdose, sometimes patients come in and they're very sleepy, somnolent, confused, sedated, sluggish. We would definitely want to try to work on that. So, everybody would say in regards to tapering, I think should be qualified saying this needs to be individualized. This is not a one stop fits everybody. Some patients are going to be a lot easier to titrate or taper down than others. So we visualize this. We try to minimize symptoms of withdrawal. Try to provide pain with non-pharmacologic therapies, with physical therapy, with non-opioid medications. So general rules. One is we want to really go slow. And general rule is 10% of the dose per week is a good starting point. Now, they may still be too quick for some folks, and it may need to be even lower, maybe per month or every couple of weeks. So we'll come back for a follow-up and have tapered themselves even quicker because they're doing well. I think communication is definitely the key, and definitely following and monitoring this closely. They need to be informed of what to look for as you're titrating down. What is overdone? What should they look for? What are more significant concerns and what are uncomfortable side effects of a tapering program.
Chris, hear me? This is Craig, Youthy.
Yeah, see.
Can I interject in here, or just one comment, and I'd like to get feedback from you and others.
Absolutely.
My experience with the person who is somewhat older, say 60 years old, I used to think that's old, not necessarily anymore, but I found if I have adult children come in with an older person who's on an opioid, and it's 90 plus MME, and they often are, I will taper them down 25 to 33% right off the bat, and the patient doesn't seem to report to me that they significant withdrawal, even though I let on that it might be incredibly difficult for them. I think they can handle it, so I kind of buffer them, and then it's not as bad as they think it is. And what really helps in this situation is the adult child comes back with that patient and says to me, God, my mom is back, my dad is back, my mom can poop again, my dad can have bowel movements. So my experience has been, at least for the older patient that comes in with the adult child or something of that sort, has been to start with a somewhat larger taper. Like if they're at 150 MMEs, 125, 110 MMEs way with success and significant withdrawal. Anybody else's experience?
I think, Dr. Youthy, this is Dr. Dietrich again. I think at high doses, I think you can certainly taper backwards about it, and I think that's what we do as well. My caveat to that is when they get down to the very bottom and you're trying to eliminate the opiate completely, it's where I see more kicking and screaming, and the folks that have just a couple of hydrocodone a day really do not want to give that last little crutch up. You know, for rheumatoid arthritis or osteoarthritis, they just really don't want to give this little bit. They sort of feel like you're everything away, and they're going to go kicking and screaming at that last step.
With you completely. I get patients that get down to 2 5-milligram hydrocodones a day, just have incredible difficulty getting down to 1 5-milligram hydrocodone a day. So yes, I'm in the same boat as you.
I think an important part of the taper, and Dr. C referred to this, is have support. And psychosocial support can be adult children, it can be spouses, it can be of them that is a very supports this and reinforces and encourages through this process. People want to feel like you're pulling the rug out from under them and that they're all alone. You know, having support in a network is definitely important. There is, working specialist if there's if there's an issue. See a little bit about pregnant patients. We also see patients with other comorbidities. I think people with health issues can be a lot more fragile and difficult to deal with, and I think they need a team approach, and you're going to need clinical psychology or psychiatry to be on board as a team with the success. And then never really a straight line. It's never from day through the end, step by step, perfectly smooth. I think you have to be somewhat flexible, and I think you have to be willing to communicate with the patients. They may have a setback, they may have a pain flare, and deviate from the plan a little bit, but that doesn't mean that you can't get back on track and back on the path and keep working towards your common goal, and you try to encourage them along the way and reinforce some of the principles that we're talking about. I think 10% is a good number, but I think as you know patients longer, you'll know people I can be a little bit more aggressive with. And at start, if you go fast and they have adverse effects, you can always, and breathe a dose or where you're going. You can adjust the duration of the taper according to their response. Medication is important. I think having staff that's comfortable communicating and teasing out these symptoms and side effects are important. I don't necessarily reverse the taper, but you may pause the taper or down the taper instead of every week. Maybe you do things the same for a couple of weeks or the remaining month, and then you take the next step at the end of the month. It depends on the individual and how well they're doing. Sometimes they have other problems going on that lead to pain or issues. Maybe they have a rheumatologic flare or they're switching medicines. So you have to kind of judge when to be aggressive and when to pull the reins a little bit. Get to the smallest available dose. You can extend between or just try it all without altogether. And oftentimes you can get patients down considerably or at least try to titrate down to the lowest possible dose, lowest effective dose. Included ME calculator, link the opiate and has a calculator. It's an app for a phone. It can be a helpful tool, and just wanted to reference this as an important tool, I think, when trying to reach patients from patches or titrate down or look at dosing. So several of you probably should have received this in format from the South Dakota Department of Social Services, and this is the Medicare DSS patients requiring opiate prescriptions starting October 1st, and really giving prescribers a heads up prior to that deadline. The state is going to start titrating or titration based of morphine equivalences or MMEs. As you can see, from October 1st of 2018 ultimately to October 1st of 2019, dosage is going to be required to be titrated down, and this follows again roughly that 10% titration of each month. It could actually happen much quicker than that, but they at least gave individuals per month. It's helpful for the ease of prescribing. You just fill a script each month. So this example, and this is actually going to be stated, and pharmacists will not fill higher than the doses based off of these dates unless prior authorization with now is by individuals, DSS, and reviewed by their review group. So far we've talked about an addiction treatment plan and how it basically involves the provider coming with a tapered schedule, but there's so much more to a comprehensive addiction treatment program. It involves mental services, medical services, education, the patient, family, potential legal services, financial issues, housing and transportation, care, vocational services. There's so many pieces of the wheel. This is one example of all the different components that come into this when trying to treat one of these individuals, which is why it's very difficult to find all pieces in certain communities or to piece this all together. In North Dakota, and the link from our DMA website, but it does talk about a variety of more services, drug and alcohol treatment centers, medication-assisted treatment in Sioux Falls, community mental health centers, some helplines, a variety of providers that do treatments in different communities, and so it does at least give prescribers and providers or physicians or to go to at least try to get patients some help, completely recognizing that there are numerous limitations, whether they have financial access, whether they have benefits that cover service facilities. Facilities only take certain payers or some comp doesn't work with some of these issues. There's a variety of limitations, but one thing that came out of the governor's opiate task force was to try to come up with a list of the services that see and evaluate individuals and could provide some of these services, specifically all lines of addiction services and mental health services, which a lot of prescribers and physicians really feel limited as far as the access. DS also a couple of different links and numbers. They have a website and a 800 number. There are certain services that are assessed. They determine whether services are indicated or not. They then determine is this something that you have private insurance that would cover? Is it private pay? Do you qualify for Medicaid if there are children or pregnant women involved, or is there state or federal services that you may qualify for? So there's another link or option to provide services for individuals. And several of these are listed out on the SDSMA website under Addiction Services and Treatment. And most of us are comfortable with, but certainly we don't always see this play out in the answer who we see, and sometimes people show up at your step already on the top rung of the ladder, or qualifications of the top rung on the ladder, but trying to educate individuals, emergency rooms, urgent cares, providers, physicians on a medication ladder, or starting with the least the least medication modalities, taking advantage of physical therapy and accurate chiropractic treatments, other options other than going to an opiate, starting with milder options before going right to the heavy hitters or the strong options, only using those if necessary, and to work through least to just as clinically indicated. I think too often we see someone who breaks their back or had a weekend injury with hydrocodone and Flexo for days and out the door, rather than starting with physical therapy or modalities or some other non-opiate ways. Despite education, we still see that show up quite often. Another way of looking at whether a ladder or a step approach, but conservative things left first, over-the-counter meds, pain patches, like reflector, topical non-steroidals, compounded agents, physical therapy, chiropractic treatment modalities, then going to like 10 electric stem, some injections, trigger points, nerve blocks, and then only working up to severe or advanced therapies. I know Yuthie's on the phone, and Paul, he's an advocate and has a very comprehensive program involving medication-assisted therapies, and sort of been a push or a movement to improve access, insurance coverage, an option for some individuals that are not able to completely titrate off or eliminate all opiates, but this allows them coverage. Epinephrine is one commonly used, and it's a weaker binding or partial opiate agonist. It has less euphoria, less dependence, lower potential for misuse, a lesser withdrawal profile. It's full, and the appropriately selected and appropriately monitored individuals is part of a treatment program. That we monitor in all those individuals, we certainly follow the South Dakota PDMP drug screens. We see them in clinic, and I think some of these people require close surveillance and communication. And functional assessment in quotations, because there's a ways that this could be sort of entered or assessed, but I think specifically, are they working? Are they pursuing recreational activities? Are these folks, not only independent with ADLs and higher level ADLs, but are they in their yard? Can they do a variety of different tasks? Out here in western South Dakota, a lot of these individuals manage, hunt, and chase big game and pull, deer and fish out of the wild. So there are ways that we sort of assess whether they're functioning or not. Mark, if we could pause and just ask if there's any questions or open it up to individuals for some questions or discussion.
Thank you, Dietrich. Phone lines are open. If anybody has any questions, you're encouraged to ask those. So, Doug, maybe I'll get it started. A couple that I wrote down as I listened to your presentation. You talked about alternatives before initiating opioids, and then also spoke about tapering. I was wondering if you could comment on, or do you have any recommendations on the incorporation of alternatives that help while tapering patients back down?
Sure. So I think we're big hits of, it depends on the individual and where their source of pain is, but often we see a lot of failed back syndrome, a lot of back or neck and arm pain. And so I think depending on what other medications are on, neuropathic agents like gabapentin or pregabalin often can be very helpful, relieving some pain and providing different type of pain relief than the opiates. Duloxetine can be very helpful, especially if depressed or they're have their components to their and dysfunction. Some topical agents not only feel good when they're applied, but can offer a little bit of a different relief. So we kind of come at it a couple of different ways like that. One thing we didn't talk about as another pharmaceutical adjunct to tapering is sometimes people run into side effects, and it can be sometimes helpful to the clonidine patch at a low dose to help with some of the side effects, really monitoring blood pressure and carefully monitoring how they're doing from a medical standpoint. But those options that sometimes we would use as adjuncts to what we're doing.
Okay, thank you. Another question I had, I've been doing some reading on this. I'm by no means a topic expert. It seems like mental health and mental illness, people currently suffering from some type of mental illness, has an impact on pain and pain management. Is there any guidance? Is there like certain mental health issues that may need to be addressed, or if you can treat those, that your chances are you're more successful in working with them on the opioids, or vice versa, that you could give us some guidance on?
Well, certainly mental health comorbidities are very complicated and intertwined with chronic pain. I think if we tease out a lot of chronic pain patients, there are certainly some health comorbidities intertwined, and I sometimes sorting those out certainly can be very helpful in managing their pain. The logistics of getting those individuals to a provider to tease out and to someone to work through some of those issues, I think is a little bit more challenging and difficult. And I think that we would hope to see a little bit of improvement in access to care and maybe the breadth or depth of that care.
Okay.
Oftentimes my mental patients have a visit or a evaluation, and that leads to initiation of a medication that then the follow-up in regards to that is several months down the line, and I just don't know that they're really part of a very close monitored comprehensive program, and so it makes it a little bit more challenging, I think.
Okay, thank you. Again, phone lines are open. If you have any questions for Dr. Dietrich, we encourage you to ask those now. Okay, Dietrich, not hearing any more at this time. Would you like to proceed?
Sure. So, kind of wrap up, I think,
Yes.
talk a little bit about. Go ahead.
Have a question?
Eric, have you walk in before we go to bed? You're gonna.
I don't think we have a question. We do have somebody on the line, though. If you could please mute phone.
So as we kind of wrap up, I think certainly at some of our moment medications, that we see in South Dakota with our prescription drug program. Obviously, hydrocodone is number one. A lot of the benzodiazepines are at the top of the list. When you decrease in those medications and the number are dropping, these are, I think, as Dr. Youthy had referred when we discussed, getting off of hydrocodone is a little bit more forward, and patients may be a little resistant to the very end. Be a little bit more of a challenge to get them completely off. I think more of a fear in titration in individuals is some of the heavy hitters. If you have somebody who's on high dose fentanyl patches, if you have somebody on very high dose or MME, morphine, morphone, Dilaudid, some of the more hitters, people are a little bit more uncomfortable in titration there. And I think going slow is certainly reasonable in those instances, depending on how they do. And we're seeing improvement. We're seeing less of these medications from 15 to 16 and 16 to 17. You can national map. South Dakota still is in the same situation as some other places, although we do have some counties and pockets we have more problem. And we can find it at some of our clinics. We know from a political standpoint that access to mental health and addiction services is going to be key. How do we prove that? I think that's going to be something that we continue to have to advocate for. And as those services become more available, making that noted to our patients, making that well known to our prescribers and physicians in our communities, that's going to be very important. Systems have started some pathways, now working through, some cyclical programs, and I think we'll just see some education and some of these directions movement throughout our state. Ultimately, as we, as physicians and prescribers, improve along these areas, and we start to find patients that want to be helped, there's a large set of people out there with addiction problems that aren't getting help. And the Governor's Opiate Task Force last week really identified that despite in the prescription opiates, the drugs, methamphetamine, heroin, and fentanyl and carfentanil, still key issues and still big issues that are causing a lot of trouble. Are still causing, unnecessary deaths, and these are individuals that really are not getting these services or getting the help that they need. And then to figure out, I think we're seeing a little bit of education. The SDSMA came up with a certification course here recently for buprenorphine, and FDA ensure qualifications or a course to allow that. I think we'll see some more programs start to exist to help management of some of these difficult patients and situations. And then we're seeing a significant amount of naltrexone used to help a lot of these instances, and some of our addicted individuals that get into paramedics, law enforcement, of situations where these are being used. Anecdotally, we hear that they're saving some lives. As of now, our state does not track this, and we don't have a good grasp on what that is or where that's at. So, Mark, I think we'll ask if there's any questions. And
okay, so once again, all phone lines have been open. Any questions for Dr. Dietrich? Comments? Okay, hearing none. Dr. Dietrich, if anybody does have questions after you've given it some thought and thought more about what you had to say today, is it okay that they reach out to you, and if so, how can they best do so? It would be they could certainly direct questions to me here at the office, and I could forward them to you if that works.
Yeah, and just an email, Mark, and questions, and then we can certainly get back to them, or reach out to me as well.
Okay, thank you. One last call out. Any questions for Dr. Dietrich before we close for the day? Okay, hearing none, I'd like to close by thanking Dr. Dietrich for sharing his knowledge with us today. I'd also like to thank all of you for participating. The next program scheduled in this series is on medication-assisted therapy, or actually more kind of what's next or what's after MAT. And we're working with Dr. Craig Youthy to be the presenter on that program. The program is currently scheduled for Tuesday, July 24th. Actually, that's today, so my mistake. It's scheduled for 1 week from today. Please check the SDSMA website, as there'll be more information on that. In closing, I'd also encourage you to take a look at our website at www.sdsma.org. As Dr. Dietrich illustrated, there's a number of tools and resources out there for you to look at and utilize. And of course, if you have any questions, please don't hesitate to contact us. With that, we'll close, and I thank you all for attending and wish you a good day.
Thanks, Chris.
Thanks.